Welcome everyone, Dr. Naveen here from UPSC MEDICO. See, jugular venous pressure or JVP is actually a clinical sign which we usually measure or which we usually look for during cardiovascular examination. And any abnormality in JVP can indicate the cardiac illness. Now, JVP is a waveform. When I say it's a waveform, when you look at the wave, as you can see in the image here, we have A wave followed by X descent, then we have a V wave followed by Y descent. So there are two descents for the wave, two ups and two downs. But from transition to A to X descent, during the X descent, there is one more wave, small wave known as C wave. We'll come back to that what it is. But as you can see, there are two waveforms which are occurring within a single JVP. If you take carotid artery pulsation, it is a single waveform. It has a systole and diastole. It has an up and down, right? But here, there are two waveforms within a single JVP. This is the first take home for you. But why these waves are coming? So what is the reason for production of these waves? When you look at A, it is small a, small alphabet, it's a wave, A wave, okay? A wave occurs during right atrial systole. So remember A for A, that is you have atrium contracting, atrium contracting. Now coming back to the picture of right atrium, okay? So I'm drawing heart here. So you have right atrium here and you have left atrium. Left atrium has pulmonary vein openings, whereas right atrium has superior vena cava and inferior vena cava. The peculiarity of these vena cava is they are valveless. Valveless. That means any change in right atrial pressure, the pressure will be also transmitted to these veins. Okay, mainly superior vena cava, followed by the jugular vein, what we get in the neck. Okay, so the pressure in the right atrium is transmitted to the veins because they are valveless. So if right atrium contracts, so I'm only taking a single picture of right atrium here. This is just superior vena cava followed by internal jugular vein. Now you have right atrium. If the right atrium contracts, the change in right atrial pressure is transmitted through SVC. So whenever there is a right atrial systole, this leads to venous distension in the SVC. So this pressure is manifested by A wave, that is right atrial systole, right? This is one thing. Next is as right atrium is contracting, okay? As right atrium is contracting, this is followed by X, means relaxation. That means right atrial relaxation. So when there is an atrial contraction, this is followed by atrial relaxation. So I am talking about right atrial relaxation. So take word X from relaxation. So atrium is relaxing. So whenever atrium relaxes, okay, at the same time, okay, the base of the atrium is pulled down by the right ventricular contraction. So slowly, as you could see here, when the atrium is relaxing and coming back to the ventricles, and you have a tricuspid valve here and you have a mitral valve here. So when atrium is relaxing, slowly the base is pulled down, the pressure is low, the pressure falls in the right atrium, leading to an X descent. So X descent, A is atrial systole, X is atrial relaxation or atrial diastole. Right? Okay, fine. Till now, fine. Now, when the atrium relaxes, okay, whenever the atrium undergoes relaxation, okay, whenever the atrium undergoes relaxation, now diastole, there is an atrial filling. So the blood starts coming into the atrium. So pressure is low. So there will be venous return. So blood is coming back during the diastole. So when blood pools up, when there is filling, when there is right atrial filling, So during the right atrial, sorry, during the right atrial filling, because there is blood inside, the pressure again increases, leading to venous distension, little bit of venous distension, and this is again is manifested by rise in pressure, which is V. This is not the level of rise or level of increase in pressure is not similar to the atrial systole. Atrial systole wave, the pressure is high, whereas here there is a little bit of pressure. This is not because of contraction, this is because of volume expansion. This is because of volume expansion, and this volume expansion, okay, because there is a volume expansion, let's remember it as V, okay, because of volume expansion, and when atrial diastole is happening, there is right ventricular contraction. Right ventricle is also contracting. Right ventricle is also contracting when the volume expansion is occurring. Right. So this is V wave. So remember it as volume expansion V. Right atrial filling. Now this is followed by opening of the tricuspid wall. So whenever tricuspid wall opens, there is fall in right atrial pressure because there is emptying of the blood from right atrium to the right ventricle. So till now, when all these things are happening, that is atrial contraction and relaxation, the tricuspid wall is closed. But as the blood fills into the right atrium, the tricuspid wall will open and the right atrial pressure will fall. The fall in right atrial pressure as the tricuspid wall opens is Y descent. Okay, so tricuspid wall opens, okay, leading to fall in right atrial pressure. So because we are using relaxation X here, the counterpart Y we are using, there is no easy way to remember it as Y. Okay, so tricuspid wall is opening, right atrial is closing. So throughout this discussion, the height of the JVP, so the height of JVP, I could say, is determined by which chamber pressure? Right atrial pressure. This is a recent MCQ. So the height of the JVP is determined by which chamber pressure? It is right atrial pressure. Now quickly look into the different waveforms. We have A form, X form, V form and Y form. Now you can ask me, what is the C form? C wave. Okay. So C wave, see, whenever right atrium is contracting, okay, why right atrium contracts? Right atrium contracts so that the blood can enter into the right ventricle. So at that time tricuspid valve is open. But when right atrium is relaxing, the X descent is coming. During that time, the tricuspid valve will close. So closure of tricuspid valve. So whenever tricuspid valve closes, remember, whenever tricuspid valve closes, there is little increase in the right atrial pressure, which will produce a little bit of wave. Just before the tricuspid valve closes, it produces an interruption in the X descent. Okay, so when valve shuts like a door, like this, valve is like this and it is shutting like a door, and this pressure will be transmitted in the JVP form in the form of C wave. So the closure of tricuspid valve, which occurs between systole to diastolic phase of right atrium, will produce a little bit of spike in the JVP, that is C wave, which is usually not visually manifested, but when you trace right atrial pressure in the ICUs, you will definitely see it, right? So A is right atrial systole, C is due to closure of the tricuspid valve, X is right atrial relaxation, V is volume expansion, which is occurring during the right ventricular contraction, that is atrial diastole, we also known as right atrial filling, and Y is Y descent, which occurs due to opening of the tricuspid valve, which leads to sudden fall in right atrial pressure. Right, sudden. If you understand these waveforms, then only it is easy for you to understand the JVP wave abnormalities. So before getting into the wave abnormalities, let's also try to understand how to examine JVP. So when I say how to examine JVP, the JVP examination is done by a method known as Lewis method. Okay, what is that method of examination of JVP? This is Lewis method. Now let's try to understand the method of examination. Look at the image here. What I could see is the position of the patient. The patient is reclining with head elevated. So the patient is reclining with head elevation, and what is the recommended degree of elevation? It is 45 degrees, with this 30 to 45 degrees, but this is how the patient is reclining. Okay, and we are also using light. Okay, the torch light should be used. If see, it's not usually easy to appreciate JVP with a normal light, okay, normal sunlight, we use a torch. Okay, and the torch should be tangential. The torch should be tangential for the examination. Okay, and neck should not be flexed. Neck should not be sharply flexed. It is important for your viva and also examination of CVC, cardiovascular system, during your final MBBS postings also. Neck should not be sharply flexed. Okay, this is one more recommendation. Now look at the sternal angle. Okay, this is the sternal angle that you see. Angle of Lewis or sternal angle. This is between a connecting point between the manubrium sternum and the body of the sternum. You have a sternal angle or angle of Lewis. You have to elevate, or you have to measure the elevation of JVP or elevation of neck veins above the sternal angle. Okay, so when you measure the elevation of neck veins above the sternal angle, for this you have to add, okay, you have to add plus 5 centimeters. Okay, we have to add plus 5 centimeters because right atrium is 5 centimeters below the sternal angle. So when you do that, normal elevation is 3 centimeters. You have to add 5 centimeters. So what is the normal JVP? The normal JVP is less than or equal to 8 centimeter H2. This is the normal JVP value, and this is how we measure. This method is known as Lewis method, wherein the patient is reclining with head 45 degree. We are using a tangential chart. We are making sure that the neck is not sharply flexed. From the sternal angle, we are trying to measure the neck vein elevation, that is highest level of pulsation. Usually this is only 3 centimeters. For this we add 5 centimeters because right atrium lies at a level of 5 centimeters below the sternal angle. When you add 3 plus 5, it is 8. So normal JVP is less than 8 centimeter H2O. Okay, so we have to use a centimeter ruler to measure this. Done. Now when you're doing this Lewis method, when you're actually measuring or actually examining the JVP, the biggest problem or confusion is close to the JVP we also have a carotid artery, as you can see here, this one in the shadow. So carotid artery pulsation and JVP pulsation, we might get confused. To differentiate these two, that is carotid pulsation, carotid is a vein, carotid is an artery, jugular is a vein. So to differentiate jugular vein pulsation from carotid artery pulsation, we have a special sign known as, very important, Moodley sign, which can be a potential question in the future. Because JVP is an important topic, you need to know about what is this Moodley sign. See, Moodley sign helps you in determining which waveform of JVP you are viewing. So I am not talking about how to differentiate jugular vein pulsation from carotid pulsation. We have different set of like 5 to 6 differences. We'll come back to that. But let's try to understand what is Moodley's sign. See, carotid artery has only one wave, systole and diastole. Whereas JVP has A, C, X, V, Y. That is wave 1 and wave 2. Now you don't know, like when you look at JVP pulsation in the examination, you don't know whether you're looking at A wave or you're looking at V wave, right? To know which wave we are looking at, simultaneously while examining JVP, at the same time simultaneously also examine or also feel for the radial pulse. Okay, also feel for the radial pulse. So once the radial pulse is felt, okay, you are examining JVP, at the same time you are feeling for the radial pulse. Once the radial pulse is felt, the wave which is immediately seen after the radial artery pulsation is V wave. So V wave is followed again by A wave. So this is the sequence, and the sequence what I am talking about is the Moodley sign. So Moodley sign helps you in knowing which waveform you're looking at. Are you looking at the A waveform of JVP or V waveform of JVP? This part is done. Coming back to the key differences between jugular vein pulsation and carotid artery pulsations. Okay, so pulsations here they are seen, here they are felt. You palpate for carotid artery, but you look for JVP. Hope you got my point. Okay, you palpate for carotid, you look for JVP. And these pulsations, okay, these are seen, these are felt. When you try to obliterate them, that means if you want to put pressure on the clavicle here, okay, if you want to obstruct this, venous pulsations are always easy. Okay, venous pulsations are easy to obliterate by putting up the pressure on clavicle, whereas carotid pulsations cannot be obliterated, but because it is little deeper, okay, and it is muscular. The arteries are highly muscular, veins are little less muscular. So this is the second key difference. Okay, and relation with, next thing is relation with respiratory cycle. So we all know JVP falls during inspiration and JVP increases during expiration, whereas no change with respiratory cycle with regards to carotid artery pulsations. Okay, and as I said, there are two pulsations per systole. Okay, per systole, but here is only one pulsation per one contraction, one pulsation per systole. This is the one more major or key difference, right? Seen, felt, easy to obliterate, cannot be obliterated. Changes with respiration, there is no change with respiration. Two pulsations per systole or one pulsation per systole. Okay, and descent is usually the descents, what you see X and Y descent, they're prominent here. The descents are not prominent. Here. This is one way of differentiating a venous pulsation from arterial pulsation. And finally, when you apply abdominal pressure, that is abdominojugular test or abdominal pressure, when abdominal pressure is applied, okay, pulsations become more prominent. And here there is no effect, there is no abdominojugular reflex. This is abdominojugular reflex. If it is present, if JVP increases, no effect on abdominal pressure. These are the key differences between jugular venous pulsation from carotid artery pulsation. So we're done with the major, introductory part. Now let's try to slowly get into what are the abnormal JVP forms that we usually see. As I already told you, you have a normal waveform ACXVY, but sometimes let's take a hypothetical scenario. This is right ventricle, this is right atrium, this is left ventricle, and this is left atrium. You have a tricuspid regurgitation condition. That means during the ventricular systole, actually the tricuspid wall is closed and right ventricular diastole is happening. So there is a C wave which is coming, okay, the C wave and X descent are coming, and you have a V wave, okay, which is because of ventricular filling. This phase gets affected because the tricuspid wall is not closing properly, and there is tricuspid regurgitation, and there is volume overload during the X phase. So X phase is gone, and the C and V wave, they fuse together, they produce a CV wave. If you see a combination wave, CV wave, with loss of X descent because of blood pooling, because of the failure of the tricuspid wall, then we are looking at tricuspid regurgitation, an important MCQ. 2 times it has come in the recent CMS exam. So CV wave is seen in tricuspid regurgitation. There is loss of X descent, and C and V waves are fusing together because during that phase of X descent, the tricuspid wall should be closed, but it is open or it is mildly open because of the regurgitation, right? That's it. So tricuspid regurgitation produces CV wave. Next is atrial fibrillation. We all know atrial contraction is the root cause for A wave, but sometimes if the atria is contracting so vigorously that almost it is kind of fibrillating, so there is no proper atrial contraction. So atrial fibrillation leads to absence of A wave because there is no proper atrial systole, there is no proper increase in the pressure of the atrium and venous distension. So absent A wave is characteristic of atrial fibrillation. As you could see only CXVY. A wave is absent. There is another scenario. Instead of vigorous contraction, I am only looking at little bit of flutter of A, that is atrial flutter. Yes, atrium is contracting vigorously, but it is able to increase the pressure. So in that case, you will see a big A wave like this. So we call this as Cannon A waves, and Cannon A waves are seen in atrial flutter and also third degree AV block. That means atria plus ventricular dissociation. That is, atria is contracting on its own, ventricle is contracting on its own. So the atria is vigorously contracting, leading to Cannon A wave. So atrial flutter and third degree AV block will produce a prominent increase in the atrial contraction and atrial pressure, leading to Cannon A waves. Cannon A waves seen in atrial flutter, third degree AV block. Absent A wave is seen in atrial fibrillation. CV wave is seen in tricuspid regurgitation. Now let's look at the descent part. As I said, you have C wave, V and Y. So why descent occurs? Y descent occurs because of the opening of the tricuspid wall. If tricuspid wall has stenosis, so tricuspid wall, instead of opening, it is stenosed with a little entry, or it is stenosed. So anything which is related to tricuspid wall opening gets affected. That means the Y descent occurs because of the tricuspid wall opening. Because it is not opening properly, the Y descent is not occurring prominently, it is delayed. So slow Y descent is characteristic of tricuspid stenosis. One more problem with tricuspid stenosis is, so at the time of atrial systole, when the time of atrium is contracting, some blood is entering into the SVC producing venous distension and A wave. At the same time, the tricuspid wall is opening and some blood is entering into the right ventricle. But if the tricuspid wall is stenosed, what happens? Already there is increase in pressure. So because of the stenosis, there is more increase in pressure, and this will produce large A wave. So large A wave in clinical literature is represented as capital A. So large A wave, slow Y descent in JVP signifies tricuspid stenosis, whereas CV wave signifies tricuspid regurgitation, and JVP is actually right atrial pressure manifestation. So we only look at tricuspid wall, not mitral wall. So we're done with 4 major abnormal JVP waveforms. I want to tell you about one more abnormal JVP waveform, that is Kussmaul sign and constrictive pericarditis and cardiac tamponade differences. First we'll finish off Kussmaul sign, we'll come to the JVP waveforms seen in case of constrictive pericarditis and cardiac tamponade. Okay, let's say, imagine that you are breathing. Your breathing cycle includes inspiration and expiration. What happens during inspiration? During inspiration, there is expansion of the chest cavity, that is, thoracic cavity is expanding. When something expands, the pressure falls. So thoracic cavity, decrease in thoracic pressure occurs. Whenever there is decrease in thoracic pressure, there is increased blood return to right side of the heart. So the more and more blood is now entering into the right atrium, through that it is going into the right ventricle. So right ventricle is expanding. The volume of the right ventricle is increasing. So now, so that the right ventricle can accommodate more and more blood. So more and more blood from right atrium goes into the right ventricle, and this right atrium is now little empty. So during inspiration, the JVP falls. As right ventricle volume increase, more blood goes into that, right atrium becomes empty, and whenever right atrial distension is low, JVP is low. So during inspiration, JVP falls. This is a normal phenomenon. During inspiration, JVP falls. Now, if JVP is not falling during inspiration, that means the right ventricle is not expanding. That means right ventricle has some restriction, maybe restrictive cardiomyopathy or pericardium. the right ventricle surrounding pericardium has effusion or constrictive pericarditis there, or there is a tamponade, or right ventricular severe failure because of the right ventricular infarction. If right ventricular filling is affected, if right ventricle is not dilating to the extent needed during inspiration, this leads to either failure to fall of JVP during inspiration or paradoxical rise. Actually, the JVP should fall during inspiration. Instead of that, because right ventricular filling is getting affected in conditions like pericardial effusion, constrictive pericarditis, pericardial tamponade, and severe right heart failure, in these conditions, because it is getting affected, you will see either failure in appropriate fall or paradoxical rise. When you see these conditions, we call this sign as Kussmaul sign. What is Kussmaul sign? Paradoxical rise in JVP during inspiration or failure to appropriate fall in JVP during inspiration. Both are Kussmaul sign. They are seen in two main conditions. One is constrictive pericarditis and other is cardiac tamponade. When you see any JVP which is not falling or rising during inspiration, then what you do, you have two conditions. That is, one is constrictive pericarditis and other is cardiac tamponade. See, cardiac tamponade is a severe condition. Okay, cardiac tamponade is a severe condition. See, what is Y descent? Y descent is the right atrium to right ventricle. I am drawing a single chamber. You have a tricuspid wall. When tricuspid wall is opening, the right ventricle should allow blood flow from right atrium to the right ventricle. When it allows blood flow, then only the Y descent will occur. Cardiac tamponade is so severe that it will not allow any blood to flow from right atrium to right ventricle because of the compression, because of the tamponade. That means there is no Y descent. Whereas constrictive pericarditis is little bit less severe or less serious condition. You will definitely see a little bit of prominent Y descent here, whereas absent Y descent is characteristic of cardiac tamponade. So when you see constrictive pericarditis, you will see both prominent X and Y descents, whereas cardiac tamponade, yes, there is a prominent X descent. There is a prominent X descent, but Y descent is absent. Okay, atrial relaxation is not affected there. That is prominent, but Y descent is absent in case of cardiac tamponade. So with the help of this, we try to cover JVP abnormalities and also what is Kussmaul sign.